Hello, and welcome to the fourth CSF podcast on axial spondyloarthritis. We'll be bringing you new episodes on a bi-monthly basis along our psoriatic arthritis podcasts, and we'll be also supplying you with monthly slide decks to help keep you up to date with the latest research and publications in the field of axial spondyloarthritis. First of all, allow me to introduce myself and my co-hosts. I'm Professor Xenofon Baraliakos. I'm a medical director and professor of rheumatology at the Ruhr University of Bochum in Germany. And today I'm joined by Dr. Sofia Ramiro, who's a consultant rheumatologist and a senior researcher at the Leiden University Medical Center in the Netherlands. If you want to find more out of these sequences and about us, use the papers that we will discuss today, and please head over to the CSF website. Sofia.
Thank you very much, Xenofon. So the papers we will be discussing today in this podcast will focus on the ASAS-EULAR recommendations for the management of axial SPA, from which we have the 2022 update that has just been published. And it will be followed by the current understanding of efficacy and safety of biological bDMARDs in patients with axial SPA, which was conducted, it's in a systematic literature review conducted to inform this update of the ASAS-EULAR recommendations. So let's start with the first paper, so the ASAS-EULAR recommendations themselves, in which both Professor Baraliakos and myself are co-authors. And it focuses on the management of patients with axial SPA, including non-pharmacological and pharmacological interventions. It includes evidence that has accumulated throughout the last years, addressing its efficacy on axial manifestations, peripheral manifestations, but also evidence on the efficacy of the different drugs on the extramusculoskeletal manifestations has been accumulating, with data available in patients with pure axial SPA, but also in other populations such as patients with psoriasis, psoriatic arthritis, or IBD. This ASAS-EULAR recommendations were for the management of axial SPA were first developed in 2006, updated in 2010, both covering only radiographic axial SPA, and then they were further updated and expanded into the entire spectrum of axial SPA in 2016. And now we will be addressing the update from 2022. So following the EULAR standardized operating procedures, two systematic literature reviews were conducted, one on non-pharmacological and non-biological treatment, and another addressing biological bDMARDs. And then in the task force meeting, the evidence was presented, discussed, and then overarching principles and recommendations were updated and followed by voting. And so I will guide you through the most important points of these recommendations. So we have 5 overarching principles that are unchanged compared to the previous version of the recommendations. And we have 15 recommendations, and they have a focus on personalized medicine. And they are mainly 8 of them are unchanged compared to the previous recommendations. 3 have minor edits on nomenclature, and 2 have relevant updates, and we have 2 completely new recommendations that were newly formulated. The first 5 recommendations focus on the treatment target, monitoring, and how the first-line pharmacological treatment is established. So starting with non-steroidal anti-inflammatory drugs as the first pharmacological choice. Then continuing, we have next recommendations dealing with analgesics and discouraging long-term glucocorticoids and conventional synthetic bDMARDs for pure axial involvement. And then we start with the parts that really are more relevant because they have more updates compared to the previous version of the recommendations. So then we start with the indication for treatment with biologicals or targeted synthetic bDMARDs. And with biologicals, we include TNF inhibitors and IL-17 inhibitors. And now we have a new drug class, the JAK inhibitors, which are considered in this version of the recommendation. So if a patient has eligibility for treatment with these molecules, then any of these drug classes can be used. And it's important to think about and to emphasize what eligibility with this treatment means. And it's a patient that has failed conventional treatment, so at least 2 NSAIDs, and that has high disease activity, which is defined with an ASAS of at least 2.1. And this is something that is new in these recommendations, because it's for the first time that high disease activity is solely defined by the presence of an ASDAS. In earlier recommendations, we also had the BASDA as an alternative, but now we have so much accumulated evidence that the ASDAS performs better, that an ASDAS score of at least 2.1 is sufficient to define high disease activity. So this, together with the failure to treatment that I mentioned, and then the presence of either elevated CRP or inflammation on the MRI or a radiographic sacroiliitis, makes the patient eligible for treatment. When patients are eligible for treatment with biologicals or targeted synthetic bDMARDs, then any of the 3 drug classes can be started, while the task force emphasizes that current practice is to start with TNF inhibitor or IL-17 inhibitor due to more accumulated evidence, experience, safety data with these drug classes. And it's important to also realize that due to the evidence that we have with extramusculoskeletal manifestations and their effect on treatment efficacy, we now have for the first time one new recommendation dealing with the presence of extramusculoskeletal manifestations, as they can help to guide treatment choice. And when there is the presence of recurrent uveitis or inflammatory bowel disease, then there is a preference for TNF monoclonal antibodies, as these have been shown to be more efficacious in the presence of these extramusculoskeletal manifestations, especially in comparison with etanercept or with secukinumab, which they were compared to. And when there is presence of significant psoriasis, then the preference goes for IL-17 inhibitors, which have shown in data borrowed from psoriatic arthritis, but then there they have shown to be even superior compared to TNF inhibitors, especially in what concerns skin outcomes. And if this first treatment choice, either biologic or targeted synthetic bDMARDs, fails, I think it's important to recommend what we did now in the task force. And actually, I think it's probably the most important recommendation that we have, a fully new recommendation where we address treatment failure by prompting ourselves to reevaluate the diagnosis and to consider the presence of comorbidities. This means that if there is a high score of an ASDAS and we are suspecting that there is high disease activity to introduce a new treatment, patient has not responded to a previous treatment, first let's think about whether the diagnosis is really correct and whether there is no presence of comorbidities like, for example, osteoarthritis or fibromyalgia, as this can contribute to a higher score of the ASDAS, for example, without really reflecting inflammatory activity and therefore not being a real target for a new treatment with biologic or targeted synthetic bDMARDs. But if in turn active axial SPA is confirmed and the patient has failed the first treatment, then it's indeed recommended to switch to another biologic or targeted synthetic bDMARD, where any switch to any drug class is recommended. And then if we reach a state when sustained remission has been achieved and we have a patient stable and in sustained remission, the recommendation is to consider tapering, where we have focused tapering solely on a biological bDMARD and without recommending tapering of a targeted synthetic bDMARD, especially because, or actually solely because, there is not yet any data on tapering of the JAK inhibitors. And the last recommendations deal with surgery and spinal fractures, and they are unchanged. So I think this is, in a nutshell, a short summary of what the recommendations tell us, and they provide healthcare professionals taking care of patients with axial SPA, patients and other relevant stakeholders with the most up-to-date evidence and expert insights in the management of patients with the axial SPA. So I think I would like to let it here in terms of the summary, and maybe if you would like to add something, Xenofon, what is for you particularly important in this update of the recommendations?
Thank you very much, Sofia. I think it was indeed very well presented in terms of going through a lot of work with very precise sentences here and guiding us through it. Well, I believe that we, as compared to the previous update, we really have come much further with these recommendations, since we have added the entire evidence we've accumulated in the last couple of years, including comparisons between biologic DMARDs, not so much when it comes to JAK inhibitors, because, as you mentioned, the accumulated evidence is not that much, but also including information about how to handle patients who do respond well and others who do not respond well to the treatment. I can comment on your question, but I also have a question for you later, because you are the lead author of this effort. First of all, what I am very much interested in is what to do if a patient does well. How to really handle that patient, especially since the discussion and the question about tapering or even stopping the treatment has come up in the very last years. And we state clearly here that indeed tapering is recommended in patients with a sustained remission. For those who always ask the question, or for those who are asking themselves, what is sustained remission? We all have said, well, if you have it for at least 6 months and you really almost more or less constantly in remission, you would consider a patient being in sustained remission. I don't know if it has to be 4, 6, or 8 months. For sure, it has to be that the physician is convinced that this patient is doing very well without any danger of relapsing. The other question I think that we need to discuss, and you can maybe comment on, Sofia, is what do we mean by indeed reevaluating the diagnosis? So what kind of situations can we face maybe in this part?
Yes, it's a very good question. Thank you. I think what we mean is take into account that these diagnoses are not always set in stone, and there's also evolution in our knowledge. Sometimes the diagnosis may have been set, maybe made 5 or 8 years ago, and there's evolving knowledge. So it's revisiting and reevaluating the features that were present and the manifestations that were present at that time, imaging and objective features, so elevated inflammatory markers that were present or absent, imaging that was performed, look again at a pelvic X-ray, look again at an MRI that was eventually performed at that time, and look from a different perspective. Sometimes diagnoses were made earlier by different colleagues, and patients are now followed up by a different doctor. So it's simply being open-minded and knowing that we can all make a diagnosis at a moment and later think about it differently. We also, if we think about also how the field evolves, we know that MRI of the sacroiliac joints is a very important and useful feature, but maybe 10 years ago, or likely 10 years ago, if we saw inflammation on the SI joints, we were sure that it was axial SPA, and nowadays we also know that there are false positives and that not always bone marrow edema on the SI joints means directly axial SPA. So it's more reassessing all the available information with a more critical look, and it can be to simply reach the conclusion that we agree with the diagnosis and we are convinced of this, and that's very good. If in doubt, it can also be a moment to perform other tests, eventually imaging, to confirm or not the diagnosis. So I think that's what I would recommend and what I understand under this recommendation and what we discussed in the task force.
That's right. We also need to consider that might be that we have the right diagnosis, but just, again, the treatment is not, as you mentioned, the treatment is not working properly. So it's not always that we question the diagnosis, as you mentioned.
No, it's only being open to look at it again, but the conclusion can very well be it's axial SPA, and then it's active disease, and then we go forward to the next step, which will be a switch of treatment.
That's right. All right, let's go over to our second paper that was a part of these recommendations. It was authored by Kaspar Webers and other colleagues, including us as co-authors. That second paper is entitled Efficacy and Safety of Biological DMARDs. And now the important part, a systematic literature review informing the 2022 update of the ASAS-EULAR recommendations for the management of axial spondyloarthritis. Now, you all have to remember that these recommendations that Sofia has already introduced are based on systematic literature reviews. And these literature reviews are, of course, also taking into account what has been published before. This means the 2016 update was certainly taken as a basis, but of course and this was the intention of this update, we discovered or checked for new evidence which has emerged in the efficacy and safety of biologic DMARDs, but also other treatments in the field of axial spondyloarthritis. Here we talk about biologic DMARDs. This means that we conducted a systematic literature review in the time after the last recommendations were published. This means 2016 to 2021. These were the years that were included. On the arguments, on the data regarding efficacy and safety of these biologic DMARDs in axial spondyloarthritis. And here we included both radiographic and non-radiographic axial spondyloarthritis. The rules are also set as such that we say that eligible study designs need to be predefined. And here we included, I would say, as always, and this has a purpose, of course, that we want to have a solid data basis for the data. So we included randomized control trials, strategy trials, and observational studies, especially the latter were for safety and extra musculoskeletal manifestations. And all the relevant efficacy and safety outcomes were included, from which we thereafter, of course, formed the recommendations the best possible way in terms of wording. Now, what did this literature review show? Overall, we have been able to include out of the many papers that were found, 148 publications. And there is bullet points that we have defined, because these are exactly the information that informs the recommendations. So first of all, we found that the efficacy of the drugs such as golimumab and certolizumab was confirmed, something that was missing in that sense in the previous recommendations. We also found, and this is extremely important, that or we state that TNF inhibitor biosimilars are equivalent to originators. We had 15 RCTs that showed data or presented data on efficacy of interleukin-17 inhibitors. And these demonstrated clinically relevant effects. This means the risk ratio versus placebo to achieve the primary outcome, which is mostly nowadays ASAS-40. The response was aligned between 1.3 and 15.3 for the radiographic AxSpA and 1.4 to 2.1 in non-radiographic AxSpA. This very simply means that there is a clear effect. These differences in the radiographic versus the non-radiographic, regarding also the range, have to do with the fact that the designs of the studies in radiographic and non-radiographic AxSpA are not always the same, with especially placebo patients being able to escape to active drug in the non-radiographic studies mainly. Now, we also have found that the efficacy of IL-17 inhibitors, this means secukinumab and ixekizumab, is demonstrated in both TNF blocker naive and TNF blocker inadequate responders. And on the other hand, we didn't find any relevant benefits in patients who were treated with IL-23 or IL-12/23 inhibitors in this indication. Also, tapering of TNF blockers by spacing, something we just discussed, was found to be non-inferior to the standard dose treatment. Spacing is always a little bit tricky in terms of these studies, because there's no sequential and slow spacing. It's more or less a direct spacing from, let's say, the full dose to half of the dose, but this is the way the studies have been done. Nevertheless, this spacing was non-inferior to the standard dose treatment. The first AxSpA treat to target trial, on the other hand, which is the other part, this means we're not spacing, but we treat to target independent of how much effort we will be giving. So this first AxSpA treat to target trial did not meet its primary endpoint, but showed improvements in other secondary endpoints. Primary endpoint was at that time the ASAS Health Index, 30% improvement. Again, not met, but other improvements in the disease activity outcomes were found. So there's always a balance of how to deal with patients who either need to be I would now offensively say pushed to a target, which is something that we already have, as I mentioned before, ASAS-40. But and in those cases where we are able to reach this very good response and sustained remission, tapering was found to be good and as good as continuous treatment with the original dosing. There were no new risks identified with TNF blockers use in observational studies. These data are lacking for IL-17 inhibitors yet. For secukinumab and etanercept, we found associations with increased risk of uveitis in observational studies compared to monoclonal TNF blockers. The study situation is varying a little bit, but this variation overall has to do with the fact that we have very low numbers of studies. For secukinumab, just one, and for etanercept, just 2 studies that were used for this literature review. So in conclusion, new evidence supports the efficacy and safety of TNF blockers, both originators and biosimilars, but also IL-17 inhibitors in both radiographic and non-radiographic AxSpA, while other cytokine blockades such as IL-23 inhibition failed to show relevant effects. And observational studies, that is what I mentioned earlier, are still needed to confirm the even longer term safety of IL-17 inhibitors. Although, again, and as mentioned before by Sofia, we have put this biologic DMARD treatment at the same level as TNF blockers in terms of current standard in daily practice. This was my part for that. I think this again is the help to provide evidence for the recommendations. So I would conclude of saying that we are certainly much ahead in terms of data generation, evidence for efficacy and safety. However, we're still missing things. And Sofia, what do you think I'm thinking of?
Well, I don't know in med directly what you are thinking directly, because there are many things I think we are missing. So let's talk about a few of them. And I'm happy that you are bringing that topic up, because I think that I would like to start by saying that we don't have head-to-head trials, and I think that's really a problem. Exactly. I think it's very positive and good that we have a larger treatment armamentarium. I think that's a very good sign for our patients. But we have to try to position them without having head-to-head trials. So what happens is that in the absence of data prioritizing one or the other drug class, we also put them at the same level, actually, in terms of the possibility to prescribe any drug class, while we emphasize that the current practice is to start with a TNF inhibitor or IL-17 inhibitor for the reasons already discussed. But actually, we do not have comparisons, and that's really a pity and something I think we would like to have, and we are needing to have, especially when we have more treatment options. I think also that the role of imaging in the monitoring of axial SPA is not clear yet. Therefore, it's not widely recommended when monitoring patients, and we monitor patients based on their clinical presentation and on ASAS and manifestations of activity of the disease. But still, I think there's still room to further investigate this and to understand whether MRI can help us in the monitoring of patients or not. And in general, I think safety is also a hot topic, especially when we talk about JAK inhibitors. I think we need to know more. We need to know about safety of the different drug classes, but particularly of the JAK inhibitors. Is the higher risk for major cardiac events in that were found with tofacitinib in rheumatoid arthritis, and also a higher risk of malignancies. Is that applicable to patients with axial SPA that are younger, have less comorbidities? We don't know, and we would like to, of course, know more about that. And I think and hope that will be extensively investigated over the next years, so that we hopefully have more information for the next updates of the recommendations.
That's right, indeed. I see that very similarly. We're missing head-to-head studies. The question is whether or not we need them. I do believe we need them, since there's more than just the clinical efficacy and safety. We have also information to gain on, let's say, radiographic progression in long term. We have information to gain on extramuscular skeletal manifestations. and so on. But this is why we're here, to obviously work on that as a research agenda and provide data maybe for the next recommendations even. And as you mentioned, we also have now JAK inhibitors, which is still an open topic in terms of both the same or similar efficacy, but also in terms of safety profiles that we need to clarify better in these patients. And I say this specifically in these patients because the patient profile itself in axial spondyloarthritis is different than the one as compared to the one in psoriatic arthritis or in rheumatoid arthritis.
Yes, totally agree.
Right. Thank you for joining us in this AxSpA podcast brought to you by the CSF. We really hope you enjoyed it and you find it useful. If you did, don't forget to subscribe to our channels on YouTube, SoundCloud, or wherever you get your podcasts from so that you don't miss any future episodes. If you want to read more about what we've discussed today, head over to cytokinesignalite.com, where you'll find detailed summary slides of each of the papers. See you next time.